Good afternoon or good morning, depending on where you are, and welcome to the second in our series of webinars exploring the question of what's driving up healthcare costs and what efforts are being made to control their rise. I'm Catherine Reed, Director of Education and Content for AHCJ. This series of webinars is sponsored by the Peterson Milbank Program for Sustainable Healthcare Costs and built on a series of webinars called Follow the Money that we at AHCJ held in collaboration with investigative reporters and editors earlier this year. There will be 2 more webinars in this series before the end of the year, so look for information about those in your AHCJ newsletter and don't forget to register. Before I introduce the moderator of today's webinar, just a reminder that we love a good Q&A. So please put your questions in the Q&A space and not the chat, and I am sure our moderator will try to get to all of them. Also, a reminder, this webinar is being recorded and can be found in its entirety on our website later today. So let's get this started. I want to introduce Reed Abelson, a reporter for the New York Times, who knows a lot about this topic we're about to discuss. Reed covers the changing landscape of healthcare in the United States and health insurance, especially how it has changed since the debut of the Affordable Care Act. She also writes about the increasing privatization of government programs like Medicare and Medicaid. Reed, it's all yours.
Thank you very much. I really appreciate it. So we are blessed with 2 speakers today. Katie Gudiksen, the executive editor of The Source on Healthcare Price and Competition, and Zachary Goldman, who is a healthcare economist at the Oregon Health Authority. And we'll start with a presentation by Katie.
Thanks, Reed. So I'm going to spend the next few minutes talking about healthcare mergers and healthcare price increases. So the title of this webinar was about hospital mergers, so let's start there. So this is a graph using data from the American Hospital Association survey of hospitals, and it shows hospitals in the US since, for the past 30 years. And you can see the nonprofit hospitals in green, government hospitals in gray, and then investor-owned or for-profit hospitals in brown. And what you can see in the middle of the chart is that there's a line that goes from 40% in 1995 to 73% of hospitals projected for next year. And that's the number of hospitals in systems. So what you can see is essentially a doubling of hospital mergers in the past 30 years. And more recently, these mergers have resulted in dominant regional systems and health systems with a large national footprint. So more than half of the hospital acquisitions that occurred between 2010 and 2019 were to an acquirer in a different commuting zone. That means the hospital systems were acquiring a hospital in a new region. And I've shown 2 recent mergers of large health systems, Intermountain and SCL Health, and Atrium and Advocate Aurora. And these health systems now cover many states across the US. In addition to sort of this M&A of hospitals themselves, there's been a lot of vertical consolidation. And when I say vertical consolidation, I mean health systems buying physicians or imaging centers, really anything that could drive referrals to the hospital. And currently, more than half of physicians are now employed by a hospital or a health system. An additional 23% are owned by corporate owners, like private equity firms or other investors. And hospital ownership of physicians can alter referral patterns of those physicians, and then also allow essentially arbitrage where the physician charges their fees. They send a bill to patients. And then the hospital can also charge their own facility fee if they own the hospital or own the location in which the physician is practicing under the hospital license. And so what has this done? This has really driven up healthcare costs. And the results won't come as a surprise to anyone here, but you can see that hospital services and medical services, I've circled those there, are increasing much more rapidly than anything else. I've put a little arrow by wages and overall inflation. And what that means is that medical costs, healthcare costs, are simply outstripping most everything else in the economy. They're becoming a bigger and bigger portion of paychecks and what people pay for out of their paychecks. And the other effect of consolidation is that there's not really any competitive pressure, or there's reduced competitive pressure on health systems to improve quality or outcomes. This is data from OECD, the Organization for Economic Cooperation and Development, and it compares a lot of countries' sort of national statistics, many of our peer nations. And you can see that not only are we way out on the right, that we spend more on healthcare than any of our other countries. I've circled the US there in red so you don't miss it, but we're also at the bottom of an aggregated measure of all kinds of quality metrics, things like maternal health, pediatric care, cancer survival rates, et cetera. You can see that the US is an outlier on both cost and quality. And the reason for that is really a large amount is a lack of competitive forces on the US market, and then trying to allow market forces to do this. So we both want a market economy, and yet we look the other way when those markets are consolidating. And so the question is, how is this impacting American employers and workers? And this was the subject of the last AHCJ's webinar. So there's more information there. I'll just highlight a very few sort of take-home points. And the first is that variation in healthcare premiums, it doesn't vary very much. It's pretty modest among people. So what happens is that it serves as a head tax. It becomes a larger portion of sort of low to middle income American incomes, and it doesn't have such a big effect on sort of CEOs or sort of people at the top end of the income spectrum. And so this is data from a study in JAMA that found that over this 20 years or so, healthcare costs have become almost 30% of the lowest income Americans' compensation. And what that means is a reduction in wages as employers are paying more for their healthcare. And this paper estimates that the average American family lost over $100,000 during that time frame in wages. Another study estimated that a hospital merger that raises prices by 5%, which is a pretty average price increase following a hospital merger, results in $32 million in lost wages in that economy and 203 job losses because employers are using that money to cover healthcare costs. So that begs the question about what government is trying to do. And the federal government honestly has been quite active in this space. In fact, one of President Biden's first executive orders was an executive order on promoting competition in the American economy. And it called for a whole of government approach to addressing harms in consolidation in all kinds of industries. But it identified agriculture, technology, and healthcare as three of the biggest industries of concern. So building on that foundation, last December, the FTC and DOJ issued new merger guidelines. And these were revisions to previous guidelines that have been around for decades. But rather than looking at mergers as horizontal or non-horizontal mergers, this really looked at mergers more holistically. And there's one set of guidelines that governs all mergers. And the FTC and DOJ wrote them to reflect modern market realities, so to update them, and the lived experience of a diverse array of market participants. So these merger guidelines really reflect a new emphasis on looking at the harms of mergers. In addition, there was a request for information, an RFI, in March, issued by the FTC, DOJ, and Health and Human Services collectively, that asked for comments on the impact of corporate greed in healthcare. That was really looking at private equity investment and other corporatizations. And in May, the DOJ announced a task force on healthcare monopolies and collusion. So you can see that the federal government has been taking action in this space. But I think, as we all know, federal action can be somewhat slow. So states have really been stepping in to fill their role as the laboratories of democracy, and are taking some action to address harms to address consolidation itself, and then the harms that come from it. There's lots and lots of policies that are being attempted at the state level, and I really can't talk about nearly all of them today. But I like to think about these in three buckets. And the first is to strengthen oversight of future consolidation, and I'll talk more about that. The second is to promote competition and improve the functioning of the market, sort of to do what states can to strengthen competitive forces. And then in the third bucket are actual restrictions on prices and sort of thinking about ways to set prices in some parts of the economy or some parts of the healthcare market that can then improve competition, improve market function. And the first one I'll talk about for just a couple minutes is to stop any competitive consolidation before it happens. And this really is, if there's enough competition in the market, this is the way markets function best. So state and federal antitrust laws prohibit transactions that substantially lessen competition or tend to create a monopoly. So we already have a law on the books that should prevent harmful consolidation. And large transactions have to file notice with the federal government before they occur. This year it's almost $120 million, but one study found that only about half of hospital mergers rise to this threshold, and nearly all transactions involving physicians or clinics don't have to report to the federal government. So this is an area where states really have stepped in, and there's a number of states that have created programs that require transactions to report to state officials before they occur. And this allows the state to have more oversight into what's happening in their market. And it's important to note that not all mergers are bad. The importance of a review program is to allow regulators or enforcers to look at the merger before they happen, because unwinding a healthcare transaction or unscrambling the egg is really hard. And so it's really important to evaluate the mergers before they happen. And so here's a table. I know that there's a lot of information here, but what I want to communicate is that there's quite a few states that require transactions to be reported to the Attorney General or the Department of Health or another market oversight entity before they occur. And you can see there's a lot of variability in how the states handle this transaction review. So on the top two rows, the notice and review, those are states that just require some kind of notification, but if a state wants to block a merger, they have to go to court and use antitrust or charitable review laws to block that merger. And on the lower level are some states that allow the AG or some other state agency to actually block a merger or disapprove a merger in an administrative review, which is then reviewable by the courts. But this allows the state to sort of have oversight over more mergers without expending such significant resources. And I should note that there are many states that show up in multiple places because they may have particular review at the Attorney General and different review at the Department of Health. So here's a map that shows just some of those, because I think this is a little easier to digest than that complicated table. And these are the states that require a nonprofit hospital to give notice to the Attorney General before there's change of control of that hospital. And you can see here that there actually are quite a lot of states that show up on this map. I will say that in some of these states, the authority is a little bit of a rubber stamp. They're just asking, were the charitable assets used appropriately? But it still serves as notice to the Attorney General, and it could really serve as a starting point for states to understand and review future transactions. And I will also say that this is a place where states really have been active. We've seen a number of states pass laws in the last few years to enhance oversight of transaction review. And so these are the three states that are really at the forefront of the efforts to review proactive mergers. Massachusetts has had the Health Policy Commission since 2012, so they really have some experience here. And more recently, Oregon and California have established these commissions to review transactions, to take in notices. I'm not going to say any more about it because we'll hear from an expert in just a second about how these operate. And I know I'm almost at the end of my time, but I want to go back to the buckets here of options that states have and just say that there are many other places that states have been active, and we can talk about them in the Q&A if people are interested. But it's important to note that a lot of anti-competitive consolidation, sort of mergers that cause prices to increase, have already occurred. And so it's really important for states to be thinking about, what can we do next? What are the kinds of market harms that we're seeing in our state, and what are some of the options that we would have to address that? And there really are quite a few for states that are interested. And so in conclusion, I would just say that it's very clear that there are market failures in some places that are simply leading to unaffordable increases in healthcare spending. And those are disproportionately hurting low and middle income Americans. But the good news is that government really is starting to move here, and it seems to be a bipartisan issue that that many state and federal lawmakers are really thinking about increasing enforcement and ways to address market consolidation. And the other important thing to know is that states are really experimenting with ways to slow cost growth, and it's really important to communicate how those tie back to economic harms and really help the public understand how these policies may help address healthcare costs. And with that, I will pass it back to Reed.
Well, thank you. I mean, this is very informative. So I had one question, which is you mentioned the difficulty of unscrambling the eggs. And a lot of the efforts, both on the federal and state level, seem to be aimed at preventing mergers or preventing consolidation, or on the other hand, sort of addressing its effects or impact. And I'm curious about the enforcement piece. I mean, have you seen anything interesting? Is there some attention to, should we consider, these already large entities, regulating them differently, breaking them up, doing some sort of enforcement action? I'm just curious where you think that is these days.
Yeah, I certainly don't think it should be off the table. I certainly think that thinking about these large national health systems, especially ones that are really shown to be driving up prices or acting in ways that are monopolistic and harming the economy. I think there really should be a lot of thought into breaking them up. I think that in terms of health systems that have really dominated a particular market, it's really hard to think about breaking up the hospital from the physicians from the clinics. You have these highly integrated systems. So I think it should be something that the enforcers definitely think about. I think it is exceptionally difficult and would only be a reasonable remedy in sort of extreme situations. But I also think it shouldn't be off the table because even understanding that is a possibility might change the behavior of some of these large systems.
Okay, well, thank you. And I think we're about to turn our attention to Zachary and what's going on in Oregon. So looking forward to your presentation.
Great. Thanks for having me. Let me share my screen here. So I wanted to convey and give you all a little information about what is happening here in Oregon. So in 2021, Oregon legislature passed a law to create Oregon's healthcare market oversight program. So through, and we call it HCMO, HCMO, Healthcare Market Oversight. So through the HCMO program, the Oregon Health Authority reviews proposed healthcare deals to make sure that they support statewide goals specifically related to cost, health equity, access to care, and quality of care. And broadly, the program aims to promote transparency, number one. Number two, support those statewide priorities that I just mentioned. And three, monitor and study those impacts. After the fact even, because there are some requirements that we have to do follow-up reviews of deals. So what entities are subject to review? It applies to healthcare entities. So entities that provide care, like hospitals, doctors' offices, dentist offices, health insurance companies like health plans, and medical groups, as well as those entities that help administer healthcare. So think like pharmacy benefit managers or PBMs, as well as management service organizations or MSOs, as well as those entities that control healthcare companies. So in some cases, private equity firms will control a healthcare company, and those entities would be subject to review for those types of transactions. What's unique about Oregon is that the Oregon Health Authority through this program has the authority to approve with conditions, or disapprove or block a proposed transaction. As Katie mentioned, that's different than how other states' programs work. And in other states, they either work with or defer their authority to their attorney general. But here in Oregon, the Oregon Health Authority has these authorities. So this is the wonky part of the presentation, but just to give you a sense of what types of transactions are subject to review, there are a couple different kind of inclusionary criteria. One is how big are these entities? So does one entity have an average of $25 million in revenue? And does the other have at least $10 million in revenue? If no, if we're talking about two really small healthcare entities, then there's no notification, there's no review. But if yes, then what type of transaction are we talking about? If it's a merger or an acquisition or a corporate affiliation, then yes, that's subject to review. But there are different flavors depending on if it's a new clinic affiliation, let's say it's a new joint venture, or let's say it's a new parent organization. That's only reviewable if certain conditions are met, and those conditions relate to any potential reductions of essential services or consolidation effects. And if yes, then there's a requirement for those entities to submit a notice, and then the Healthcare Market Oversight Program reviews that proposed transaction. If no, then no notice is required. So it's just on or off. In terms of the review itself, so the Healthcare Market Oversight Program looks at how the proposed transaction could affect healthcare costs, access to care, the quality of that care, health equity, as well as market consolidation. So these are kind of the big buckets that we're looking at. The core tenet, and I mentioned this at the top, transparency and public input are critical and a core ingredient to this program. So for example, when we receive a notice of a proposed transaction, we post that online, and all public-facing materials are posted online. We then notify the public through what's called a Gov delivery. It's kind of an email list, as well as other communications to announce to the public that a new transaction is being proposed, and the program is currently reviewing it. And we solicit public comment and public engagement. So the program accepts public comment for every proposed transaction and incorporates that into the review itself. It's published along with the review, and all public comments are posted online. For some reviews, we're talking about hundreds of public input, which is great, and they do meaningfully contribute to the review itself. Now, in terms of the mechanics of the program, we do what's called an initial preliminary review. It takes 30 days. And if certain criteria are met, then a transaction can be subject to a broader review, what's called a comprehensive review, and that's a longer term review. So during that comprehensive review, the Healthcare Market Oversight Program may create listening sessions to allow for new venues or additional venues for the public to inform and provide their input. We may create what's called a community review board that's specific to a given transaction. And this consists of community members who might be affected by a proposed transaction to allow them to share their experience and concerns about what the entities are proposing. Then that community review board makes a formal recommendation to the program. The community review board may also opt to convene what's called a public hearing to share information about the transaction and hear potentially from the entities involved in the transaction and the broader public. Here's just a snapshot of our website as an example to show that we publish all the materials for every transaction. So we have a bit of a kind of a timeline so folks can see where we are. And then at the bottom, we have hyperlinks to all the different publications. And this includes oftentimes appendices and attachments that the entities submit to kind of help explain and provide greater context for their proposed transaction. And you'll see at the top Kroger, Albertsons, and you might be thinking, well, those are two grocery stores. I don't know why the Healthcare Market Oversight Program is talking about that. Well, let's dig into that. As it so happens, Kroger and Albertsons here in Oregon are the two largest retail pharmacies in the state. And the proposal here, and so we are reviewing it because of that pharmacy connection. So Kroger is planning to acquire Albertsons. The program is reviewing for effects on prescription drug services. There is a potential to impact a large number of people in Oregon. There's a potential to significantly impact access to care. And we did create a community review board, and they subsequently recommended disapproval of this transaction. It's currently still undergoing a comprehensive review. I'll note that both Kroger and Albertsons, they're each about 15% of our retail pharmacy market. As I said before, they're the two largest. So if they were combined, we're looking at an entity with about 30%, 30% of the market. Here's a map showing the regional kind of diversity. They're all over the state. The upper left cluster, if folks aren't familiar with the geography of Oregon, that's Portland. And then if you go south, that's kind of Salem, Eugene area. That's what's called the I-5 corridor. And then we have locations throughout the state. So clearly there's a lot of potential impact here for a lot of people here in Oregon. The link at the bottom is to our preliminary report. Feel free to peruse that. And then, as I mentioned before, all materials, the preliminary report, the initial notice, subsequent requests for information that we sent to the entities and then they answered, that is all available online. Here's just a couple links to our program. I'll just end by saying, again, transparency and kind of public engagement is key. Even if you're in a state and you're reporting on a state that doesn't have a program like this, I'd encourage you to connect with their attorney general or their other government relations folks or their public relations folks to see kind of, are these notices coming in and is the public aware of them? Sometimes there are notification requirements in states, but maybe there's just not a whole lot of buzz about it. So we try to push that information out as well as we can and try to connect with folks and solicit input for those transactions. We find it really meaningful for us. So with that, I'll stop and happy to answer any questions.
Great. This was really interesting. One question. I'm curious if you could give folks a sense of sort of, why Oregon is at the forefront. What were some of the political or economic factors that really led to the creation of an entity that really actually has a lot of authority to review these deals?
Yeah, so back in 2021, the state legislature was debating how to think about healthcare consolidation. At the time, COVID was on the forefront of all our minds. There was a concern that COVID and the subsequent kind of effects on healthcare utilization and the change of trends that we were seeing may result in some entities struggling financially, potentially, where maybe other entities were not struggling. And so, I think there was kind of a notion that might there be a consolidation boom shortly thereafter COVID. At least that was kind of the sentiment shared during testimony in the legislature. And thus this program was created. There was another kind of angle to the as the bill was working its way through the legislature, and that was ensuring that access to services would be protected. It does happen sometimes when after a acquisition, after a merger, certain services are no longer offered. There are many articles and kind of anecdotal evidence of emergency department closures or maternity wards closures or certain kinds of care, be they reproductive health care or other types of care, no longer offered after an acquisition. So I think that was also part of the discussion. And then that was in 21, and then we launched in 22 and been operating for 2.5 years or so.
Okay. All right, well, that's really helpful. So I'm going to start looking at the questions in the Q&A. Again, a reminder, just put them in and I'll get to as many as possible. And actually, the first question I think is interesting, and maybe both of you want to take a swing from Mark Taylor. What are the barriers at the state level to challenging hospital mergers, and how are state AGs and consumer organizations trying to overcome them?
Maybe I'll take a first stab and Zachary can talk about Oregon. But I think at the highest level, the three barriers that I think are the biggest are, one, just resources. Sort of, can the state really evaluate these mergers in a comprehensive way? I think the second barrier is data, maybe a little bit less with hospital mergers, but I think especially with sort of trying to understand who already owns a physician clinic or some entity, understanding how prices may change or kind of what the referral patterns already are. So I think data is another big challenge. And I think the third big challenge is that in many cases, in almost all merger cases that I've seen, the hospital's claiming financial distress, especially after the pandemic. And a lot of times, it's a very reasonable claim to make, but trying to understand what would happen if we disallowed this merger, or what kinds of conditions can we put on a merger? I think trying to understand the financial status of hospitals and what is reasonable, because in many areas it may make, especially rural areas, et cetera, it may make sense to have one monopolistic hospital because that's, you know, that's what the community will support. But then how can the state really make sure that that hospital, the prices and so forth, the services it's providing, the access, keeping, as Zachary said, labor and delivery or emergency open, how can they really make sure that the hospital is serving the needs of the community? So I do think there are 3 barriers, and it just makes it really hard for state officials to evaluate a merger as it comes in.
I'll just add one point. I agree with that. We've reviewed a number of transactions thus far, and as I mentioned before, we have the ability to impose conditions on an approval. And there have been times in which we require those entities, so we impose a condition to fulfill a commitment that they made in their notice. So they're coming to the table saying, well, this is why we're engaging in a transaction. We want to achieve X, Y, and Z. And so there have been times when we make that a condition, and we can follow up with that a year, 2 years, and 5 years after the proposed transaction, which we are statutorily required to do. So the ability for us to impose conditions, I think, is really helpful to kind of keep that accountability present.
Okay. The next question, I think maybe Katie wants to answer, and I would broaden it slightly. It's from Merrill Davids. Do you have any data on how often hospital consolidation leads to reduced services, like, you know, closing maternity ward or whatever in a given market, or how, you know, in general, how should one think about both research into this area and the kind of data that exists?
Yeah, I think this is an area that could use more research. I mean, there's certainly studies that show it closes in anecdotal, it's not even just anecdotal, but news reporting that shows how communities are deeply affected after a merger when certain services are closed, or just even brought into sort of the metropolitan hospital, et cetera, sort of transferred to another hospital in that system. I think a lot of the studies are actually relatively difficult to parse out on a national level, because in some cases they will claim that the hospital is open, we managed to maintain maternity services because of this merger. And I think it really requires sort of a more detailed analysis. We've done some looking at this, but it was a little bit hard because our study period included COVID, which sort of puts a blip in all of these sort of analyses. But I do think it's an area that's really ripe for future research, because I think there's clear evidence that it's happening both ways, that both consolidation is causing closure of some of these services in some cases, and it's also potentially keeping hospitals open and keeping those services in the community following some mergers.
The next question, Zachary, actually, and this is from Katie Golvala. And it's basically asking whether Oregon has some sort of, you know, health plan or sort of overarching health plan that would outlines the health needs of the state to help, you know, you make your decisions. For example, if you're weighing sort of closing a rural labor and delivery unit, is there a guide for how far someone should have to travel to get to deliver somewhere? So I guess the question, yeah, I think that's an interesting issue, and I'm curious, you know, how Oregon handles that.
Yeah, so the Oregon Health Authority has a goal to eliminate health inequities by 2030. So that's kind of a foundational goal that we're working towards. Everything we do at the authority relates to that, including the Healthcare Market Oversight Program. We also have published, and our Oregon Health Policy Board, which is kind of an overarching entity, has approved kind of a framework for how we think about these transactions. You know, impact to consumers, particularly on consumer costs, you know, ensuring quality is at least maintained or improved, right? So there's some kind of core tenets there. In regards to distance to travel, we'll look at, you know, I know CMS has some metrics about measuring geographic distance, time travel to or travel time to get to a certain facility. So we borrow some of those metrics when we're looking at different transactions. And each transaction review is its own review, right? It really depends on the fact pattern of the case, kind of what community are we talking about, what types of facilities are we talking about, what types of services are offered in those facilities, and who is served at those facilities. Do folks with Medicaid, do they access those facilities? Is it predominantly folks with Medicare, right? So it really kind of depends on the situation on the ground, and every transaction review kind of is its own review.
So this, I'm going to, on some level, sort of merge some of the questions, but I think there are sort of two buckets. One is, the issue of sort of why a hospital or some other entity might argue that they need to consolidate. Again, Katie had mentioned actually maybe it's COVID or financial strains, as you both mentioned. But I'm just curious, sort of how you think about the sort of defense of the mergers, the justification for the mergers and consolidation. And so if you would both take a swing at that. Katie, why don't you start?
Sure. I think that there are definitely mergers in which sort of having better access to capital, allowing investment in the community. You can think of a lot of reasons why acquisition of a hospital could, in theory, be pro-competitive. And one of the big ones there is keeping accesses open to that community, and in addition, quality. So if you have a large system that has lots of streamlined practice guidelines, et cetera, that could be beneficial to the hospital. I would say two things. I would say that in antitrust merger review, one of the considerations is, could we achieve these benefits without an actual merger? So are there things like affiliations or other ways short of a merger that we could get these same benefits? And in many cases, that could be true. I think in terms of streamlining operations costs. So there is some evidence. There's some pretty good evidence that if independent hospitals acquired, sort of the operational costs will decline. But I think the evidence that shows that those savings and costs are passed on to either insurers or patients, employers, is very scant. I think that is something that really needs to be considered when evaluating a merger. But certainly there could be pro-competitive benefits there. And if we're talking about sort of acquisitions of smaller entities like physician groups or clinics, certainly sort of streamlined care or these advanced payment models, value-based payments, et cetera, could be considered. But I think the people evaluating the merger need to be sure that those benefits are realized. So it's easy to promise that we're going to increase streamlined care, et cetera. I think a lot of the data is showing the opposite. So once a hospital buys a physician clinic, the physicians are more likely to order tests at that hospital, increasing costs, and then also order more unnecessary MRIs, et cetera. There's a number of studies showing that. So there's a lot of potential benefits, but I think the people who are evaluating them need to look at that carefully and critically. And as Zachary said, sort of place conditions that make the entities responsible for the things that they're promising when they're proposing these mergers.
I'll just add that statutorily, we have a process for an emergency exemption. So if there's a solvency concern, so if a clinic or some kind of healthcare entity is kind of closing its doors, it's going out of business because its finances are so precarious, and another entity is willing to come in and kind of prop them up through an acquisition, a merger, some kind of partnership, then there is a process by which they can request an emergency exemption from review to allow them to kind of expeditiously close that deal to keep the doors open. So that's in statute, and we have a whole process, regulatory process to address that.
So to follow up on that a little bit, Zachary, I'll ask you. Hannah Manelis asked, Zachary, are there accountability mechanisms or penalties, really, right? That somehow when these entities, if you do impose conditions on them, if the entities, fail to fulfill those conditions, what happens, right? Is there really any consequence?
Yeah, we have a variety of legal recourse there, injunctions, stays. Even before we get there, I think there's some power in just publishing the fact that entities are not in compliance with state condition. I think that has a lot of weight to it. And as Katie mentioned, I mean, we do have the authority to kind of unwind transactions. That is, for that's challenging to do, but that is kind of an ultimate accountability mechanism. But multiple legal options there that we would pursue in that case.
Katie, this is from Joe Burns. You had a slide comparing the U.S. with other high-income nations, showing obviously that the U.S. is an outlier. What do you think the U.S. can learn about other countries in terms of their keeping costs down? I mean, are there things that either the states are considering that are sort of modeled after other countries, or, I'm curious what you think.
Yeah, I think one of the big differences is that most of those countries don't require competitive forces to deliver healthcare. So they're sort of government, either they're single payer or sort of government set rates, et cetera. I think the big difference in the United States is that, we ask the market forces to deliver healthcare at high quality and low costs, and then we don't really make sure that those markets are functioning properly. So we allow, I think it's over 90% of the markets met the government thresholds for highly consolidated. So if 90% of our markets are meeting that threshold, the markets just aren't functioning very well. Most of those other countries have some sort of rate setting, some way of the government setting prices, and many of the options that I put in that third bucket really do come from those countries. So maybe to just give one example, the state of Maryland has basically set hospital prices for decades, and they have this system of hospital global budgets, in that the hospital gets a set amount of money, and then they can plan for the amount of money they're going to get this year. And there are other states that are sort of starting to look at things like that. There's a number of considerations if a state wants to go down that path, and I've heard interest. Certainly no other state has sort of taken it on yet, but I think there is interest in moving that way.
Okay. And are there, I mean, we're talking a lot about competition, and I'm just curious in terms of are there specific proposals that you think, either of you think, potentially make the market more effective? I mean, not so much addressing the harm, but really sort of are targeted at sort of changing the market dynamics.
I think there's a number of them that sort of kind of try and improve small things. So things like banning, things like anti-tiering, anti-steering terms. That's been a handful of states have passed laws, and more have considered it, and the federal government has even considered it. Banning things like facility fees, or requiring site neutral payments, so you pay the same amount whether or not your physician is owned or operated by a hospital or somewhere else. I think that together, a whole lot of these proposals sort of get us to a more competitive market. But I think that, as I said, I think many of the markets are just so consolidated that without new entrants and sort of really new sort of ways of delivering care, I think we're sort of fighting an uphill battle. I don't know if
Zachary, do you have yeah.
Oh, just one other thing that I've kind of seen in the literature, and that is the prevalence of non-compete clauses for physicians and other providers, by which, if they're employed by an entity, and let's say that entity has multiple locations around a state or in a region, and their contract requires that they can't practice within X number of miles from any region. In cases that results in a provider having to move potentially, or otherwise kind of leave that area to continue practicing if they want to switch employers. So I've seen some kind of research about that, which is particularly interesting.
Okay. Sort of a practical question from Carl Stark for both of you. Can you talk about which records are open to reporters in Oregon and in other states about hospital consolidation, and what the records might show, how you might be able to use the records?
Yeah, I'm happy to take that one on. That's a great question. So because we here in Oregon in the healthcare market oversight program focus so much on transparency, you'll see a lot of records for a given transaction already posted on our website. In fact, there are times when we receive a FOIA or a public records request, and the answer is, here's the link. It's already posted. Here's all the information. Now, to be fair, we do receive some confidential and trade secret information, so we can't post that, but we require the entities to post the black line documents to show the public kind of what's being redacted, as well as a redaction log to show, oh, here's a document in its entirety. It's the agreement itself, or something like that. So we're as transparent as we can be while complying with other laws and statutes that we have to comply with. So we take that transparency piece very seriously.
And what about in other places? I mean, do either of you have a sense of sort of, where people can look?
So I would maybe jump in and just say California and Massachusetts sort of have very similar reporting in terms of like particular transactions. They all both post the notice and that kind of thing. I think there's a lot more hospital transparency out there. So CMS has a lot of information about hospital ownership. Most states, Department of Health, or in California, the Department of Healthcare Access and Information has a lot of information about hospital ownership. Medicaid programs often have that information. In terms of physician and sort of clinic ownership, I think that's a lot more, could use a lot more transparency. But I think in terms of hospitals, most states maintain some of that. And certainly in terms of transactions, Oregon, California, and Massachusetts post lots of information about the given transactions.
This is sort of a meta question, if you will. It's from Richard Gibson, but I'll ask you both. I mean, and it's partly because of this just statistics you cite. I mean, so much of the market is already consolidated. I mean, it gets to the question of whether, in fact, there can be a market that, in fact, marketplace competition will, in fact, deliver better care and lower prices. And I'm curious sort of how you think about that. Whether, because obviously some, one could argue price controls, for example, sort of are throwing in the towel, right? They're saying, we just can't fix this. We can only fix the effects. So I'd be interested in having both of you just address, that fundamental question. And it's one actually, my editors like to ask me a lot too. So I'll steal your answers.
I would say, maybe to jump in first, I would say that there probably are some cities that do have enough hospitals that in theory they should be competitive. We kind of just finished up a paper where we interviewed a lot of employers and insurers in the area and found out, maybe not surprisingly, that basically all the large insurers contract with all the large hospitals. So there really isn't any, rather than it used to be, the economic theory says there should be some competitive force that says if the price gets too high, the insurer is going to drop them from the network. What we found is actually it's almost the opposite. So if an insurer didn't acquiesce to sort of a price increase demand from the hospital system, the health system would threaten to go out of network, and then the insurer would risk losing their contract with their employers because the employers really wanted these broad networks. And I think it comes down to sort of a lack of information. So what it means is that there really isn't any competitive force in the insurer health system negotiation. And employers, there's been such an obfuscation of data and employers not being able to even access their own claims data. I mean, there is some movement there, but I think just employers haven't had the information they need to sort of make these kinds of competitive, assessments. Is this worth the amount of money that's going up each year in premiums? So I think just the whole market is sort of lack of competitive forces from A to Z. Yeah.
Zachary, do you want to add anything or?
Just that, I think competition does typically result in good things. And I think about, the average physician is pretty competitive. they had to compete to get into med school. They had to compete during residency. So I think on an individual level, I think there's probably there's a lot of merit to having a healthy competitive market. I mean, I'm an economics guy, so that's I kind of look towards the value of that competition. And when a market is not competitive, or if an actor is deploying anti-competitive tactics, then that can be problematic.
Yeah, maybe if I could just add, I think that competition, even when there are prices sort of set, competition can do good things for quality. And so this has been seen in England, where the prices are sort of set by the government, but then physicians actually compete with each other to see patients. And so, patient experience, quality, et cetera, can improve. And also in Maryland, where I talked about sort of hospital prices being set, they actually saw an increase in the number of insurers coming to the market because they didn't have, it was easier to enter the market because they didn't have to negotiate with these large health systems, and they could actually deliver care in a more streamlined way, or really deliver on benefits to both employers and patients. So I think that's two cases where sort of some form of rate setting actually increased competition over non-price factors.
This is a question from me, and I'm just curious about, sometimes I've heard a tension between different agencies, federal, state, sometimes, about sort of specific combinations. And I'm curious whether you think we're going to see more of that. I mean, how cooperative do you think that the state and federal agencies are? And, both of you, if you wouldn't mind taking a swing.
I can start that and just say, so we work really closely with the Department of Justice here in Oregon, because the antitrust division is within the DOJ there, as is charitable activities, which is the office that kind of oversees nonprofit entities. And if they're being acquired by a for-profit entity, for example, that would be a charitable activities issue. So we work really close with our DOJ, as well as our insurance regulator here in Oregon. It's called Department of Consumer Business Services, because the insurance regulator also has some regulatory oversight over carriers, health insurance companies. So if one's going to buy another or something like that. So we work really closely with those entities, and we have our own authority. So we do kind of we do embark upon our own reviews, because sometimes those reviews have slightly different priorities in statute. So we do kind of respect those different lanes. Regarding Reed, you mentioned kind of collaboration with the federal government. So we do kind of watch what's happening on the FTC level. For example, the Kroger-Albertsons deal that I mentioned before, we are subjecting that to a comprehensive review right now, and it's also in federal court. Happens to be here in Oregon, but it's in federal court, and the FTC is arguing on that case, and we're going to see kind of what happens there. Obviously, there's some potential impact. If the FTC blocks it entirely, then that influences our review and the outcome of the transaction. So although we're not kind of co-reviewing it necessarily, we have our own authorities. We are for sure keeping an eye on what's happening at the federal level.
I would just add, I think that's a pretty common approach. So on that table I showed where some states have authority in the Department of Health and the AG's office, for example, they tend to have different priorities or different criteria for review, and there tends to be a pretty high degree, at least, of communication between the two, and then also the federal government. There may be less collaboration there, but certainly wanting to do the right thing for consumers.
And a reminder to folks, put your questions in the Q&A. But one follow-up on that somebody had asked: what happens when, say, you decide, hey, that merger isn't going to go through, like the one we're just talking about, and the feds say no, green light? What happens then?
So it wouldn't be able to go through here in the state.
Okay.
We don't have any jurisdiction over any other state, so anything can happen in Washington State, California, Idaho, Montana, But if we were to decide one path, and that differed from say a FTC decision or a judge's decision, then our decision would only impact the state. Yeah.
And then a question from Jennifer Brown, say a small nonprofit hospital is bought by a much larger system. What happens to the value of the assets of the small hospital? In other words, does that, and you see this sometimes when a for-profit entity buys a nonprofit, but, when do the assets end up in a foundation or, going to the community? And how does that, again, enter your thinking about all of this?
It's a good question. It depends a lot if the acquiring entity is in the same state or a different state. Usually the Attorney General has oversight over the charitable assets. And so often there's a condition that they will put the assets in a foundation, et cetera. Usually there's a requirement that it stays in the same state. So if it's an out-of-state acquirer, usually they have to stay with the hospital. But really it is, I think, pretty transaction specific in terms of what happens.
Yeah. Yeah, it really does depend on that structure of the transaction. In that case, the Healthcare Market Oversight Program would defer that component to the Attorney General and the Department of Justice, because that fits squarely in charitable activities. Okay. It's part of the transaction, so we would kind of consider it along with everything else. But put it this way, that I think the charitable activity section in DOJ would be interested in looking at that.
So I think we have one more question, Matthew Ungs, and this is again, a sort of going back to basics. What's your sense about whether reporters even know how to measure the cost or price for hospitals and physicians? I mean, especially if you're reporting on a potential merger, what kind of reporting baseline measures? They're talking about the increase, but you don't know if it's high or low. And so I'm just curious again, like how one should be thinking about reporting it in ways that would be very helpful to folks.
Yeah, I can start, and I'm going to show my kind of Oregon bias here. And I know some states do this too, but not all of them. So we publish a lot of data about hospital prices. So right now you can go on a dashboard. I can send the link in the chat to show kind of the median commercial price that a hospital receives for a specific surgery, a specific procedure, a knee replacement, and you can compare. Oh, at this hospital it's $3,000. At this other hospital it's $12,000. Oh, that's interesting. So so that information is obviously publicly available here in Oregon, but we use that kind of information. We have a claims database that we leverage for the Healthcare Market Oversight Program, so we can see how have prices grown over the past 5-10 years, and how does that compare to the entity that's potentially going to be acquired, and how does that compare to regional actors as well, other competitors. So that all filters into the cost and access analysis.
I would add maybe 2 data sources. So the RAND Corporation has data where every hospital is benchmarked to Medicare. So you can see they have kind of an average price for the hospital. And it's a very first assessment of which hospitals or markets are very expensive. And the National Academy of State Health Policy, NASHP, has a price transparency tool where you can import Medicare cost reports and sort of get a baseline. And I would say both of those are great places to start if you're looking at things like that.
Yeah, I completely agree with Katie. Those are great resources.
Well, thank you both very, very much. I mean, this has been really, I think, really informative. Anyone who came in late or wants to refer this or tell a friend or an enemy about this, the webinar is recorded on the website for AHCJ. And so, please see it there. But thank you very much.
Thank you.
Thanks for having me.
Yeah.